how do you take a history in surgery? Specifically, how do you take a pain history in surgery? If you're a medical student, an intern, or even a junior resident, today is going to be absolute gold. I'm going to take you through how I do my history every single day. Let's do it. Welcome back to Citizen Surgeon. My name's Dr. Eric Pearson. I'm a pediatric surgeon, and I'm pumped that you're here. Let's get you comfortable on the exams, on the ward, in the ICU. And today we're focusing on how to take that patient history. Now, this is really specific to surgery and really specific to pain. So you have that patient that comes in with abdominal pain. We're going to go through how to elicit all of the information from that patient, make it really easy. The story behind this is when I was a third-year medical student in Royal College of Surgeons in Ireland, I had a surgery resident who sat us down and said, look, this is how you take the history. You have to take it this way, or I suggest that you take it this way, so you take it the same way every time. And even when you take that particular patient's history, you take that particular patient's history the same way every time, and then you're going to be able to know the differences and how that pain is progressing or how that patient is changing over hours or even days. All right, so there's two reasons that I take the history this way. Number one is it is in a logical progression. So when you ask those questions, it's in a logical order. It's not all over the place, all right? And so when you go to present that patient, either writing it in your note for the HPI or the history presenting complaint, or you're presenting to your attending in the middle of the night, you're going to be able to give a really tight bullet HPI that describes that patient's history. All right, so I'm really excited to show it to you. The second reason is because in coding, when you are putting your history together and the hospital wants to code that or bill that, they need 8 features in the HPI, all right? So what I'm going to give you 10. So every time you're going to have that note with 8 features, at least 8 features of the HPI, and you're going to totally crush it, all right? So let's go through each of these. Actually, first, let's talk about our references. So I have 2 awesome references for you today. Number 1, must read. If you're a medical student, read, must read. This is Zachary Cope's Diagnosis of the Acute Abdomen. It's old school, all right? But this is gonna give you all those little subtleties, all those things in the abdominal exam and the history that come out for most abdominal pathologies, all right? So I'll put the link for this in the description below, but definitely check this out. It's one of my favorite books. I read it as a medical student, reread it as a resident multiple times. I teach the book. I mean, it's totally awesome. All right. The second book, if you're a medical student and you need a book on the physical examination, I actually put both of these books in the best books video, and I can put a link to that. All right. But Talley and O'Connor's Clinical Examination is by far the best book on history and physical examination. We used it every day during medical school, and I still refer to it. So that is absolute gold. So check that out. Okay, let's get into the history. So the acronym makes no sense, but after a few times, you will remember it no problem. Okay, it goes SRNOPDSARA. What does that mean? SRNOPDSARA. The resident that taught it to me was like, staff registered nurse, outpatient department, Sarah. That's how you remember it. Well, that made absolutely no sense to me, but just using it over and over again made sense because it's a logical progression. So let's start with S. What does S mean? S is the site. Where is the pain located? And when I'm asking this, I want to ask the patient, can you point to where the pain is with one finger? I don't want to see their hand moving all over the abdomen. I want you to take one finger and point to where the pain is the most severe. And that's going to be your S, site. Next is R, radiation. So where does the pain move? Or does it move at all? So that's radiation. So you have site and radiation. All right, N, that's for nature. So what does the pain feel like? Is it a sharp, stabbing pain like a knife? Or is it a dull, crampy pain? For me, I just keep those two absolutes. Is it a dull, crampy pain? Or is it a sharp, stabbing pain that catches your breath? All right, so that's N. So we have site, radiation, nature. So next is onset. When did you first get this pain? So if you're dealing with a patient with symptomatic cholelithiasis or symptomatic gallstone disease, maybe this pain started months ago or a year ago, and they're having intermittent crampy pain, all right? So when did you first get this pain? In appendicitis, usually they'll say, oh, a couple of days ago, and it's been constant since that. So it's really important. So you got site, radiation, nature, now you have onset. So P is periodicity. Is the pain constant or does it come and go? If the pain comes and goes, how long does the pain last? And how long is the interval between these painful episodes? So in appendicitis, for example, they might say, no, this is a pain. It started last night. It's been constant with no periodicity, all right? Different might be a patient with symptomatic cholelithiasis. They might say, oh, it started 6 months ago. I get the pain a few times a week. When it comes on after meals, especially fatty meals. It lasts for about an hour and it's really severe and then it goes away. Contrast that with a kidney stone pain. So a kidney stone pain might be a sharp pain. They're moving all over the place. They can't get comfortable and it might come on every few minutes with an extremely sharp pain and then they'll have some relief. So all of the different differential diagnoses in the abdomen typically have a particular pain pattern. And this periodicity is going to help give you a lot of data to ask some more specific questions that are going to lead you to that diagnosis. So duration, this gets to how long do you get the pain when it comes on. So we touched on that a bit with periodicity, but that is really important. Specifically, for example, appendicitis. So a constant pain that's been there for 24 to 36 hours, that's going to be typical of appendicitis type pain if that's located in the right part of the abdomen and of course has a particular story. And I did put together a nice video on acute appendicitis as well as how to evaluate the acute abdomen, and I'll put links to that above. So we've looked at site, radiation, nature. We've talked about the timing with onset, periodicity, and duration. And now we're going to get to SARA. So the second S, this is severity. So on a scale from 0 to 10, 10 being the worst pain that you've ever had, where does this rank? Okay, and I just have the patient give me a number, and that gives me an idea how severe the pain is when it's at its worst. I also want to get an idea of how bad the pain is now. There are some differential diagnoses. For instance, appendicitis, you typically get this constant, gradually progressing pain, but if it perforates, you have perforated appendicitis, typically you get some relief of the pain, and then it'll start to get worse again as peritonitis sets in or an abscess forms. So like I said, each of the different differentials in the abdomen has a particular pattern, but if you can get to the severity of the pain, that'll give you an idea of how bad it is for the patient at this particular time and what is it at its worst. A is aggravating. So what makes the pain worse? Okay, so does eating fatty foods make you think of symptomatic cholelithiasis? Does moving make it worse? So typically that patient with acute appendicitis, they'll be glued to the bed. They don't want to move. If you ask them, for example, oh, on the car ride, did you feel every bump in the road? They're going to say, yes, I felt every bump in the road. That's going to give you an idea of does the patient have peritonitis. Contrast that with a kidney stone, that patient's going to be moving all over. So moving doesn't bother the patient with an obstructed kidney stone, but appendicitis, moving really bothers them. Now after A, so you have severity, aggravating. R is relieving. So what makes the pain better? Okay, does food avoidance make the pain better? Does lying still make the pain better? Does vomiting make the pain better? Do any medications make the pain better? So R is relieving, and this also gives you some data that'll help you nail that differential diagnosis. Now, the final one is associated, A for associated. So what is associated with the pain? So do you have nausea and vomiting? Is there associated fever and rigors? Do you have associated blood in the urine? Is there jaundice associated with the pain? All of these associated factors will help with your differential diagnosis and get you to focus in on one particular, one of a couple differential diagnoses on why this patient has presented with abdominal pain and why you're being consulted to find out if this is a surgical cause or could be ameliorated or treated with surgery. Okay, so let's go over those one more time. So you have SRNOPDSARA, all right, site, radiation, nature, onset, periodicity, duration, severity, aggravating, relieving, and associated. So let's take a couple of clinical cases. Let's see how this all comes together. So first, let's say you have that 7-year-old that the ED consulted you on for abdominal pain, and you go and you take your history. This, in my opinion, would be an awesome bullet to present to your attending or your senior resident, or even write in your note for your HPI. So this is a 7-year-old boy with right lower quadrant pain that's non-radiating. It's crampy and dull in nature. It started yesterday evening and has been constant with no periodicity. It reaches a severity of 8 out of 10. It's aggravated with any movement, pressure, touching the abdomen. It's relieved by lying still, was relieved with some pain medication, and it's been associated with nausea, vomiting, and diarrhea. All right, so what differential does this lead to? So some of the things as a surgeon I think about is, could this be acute appendicitis? Could this be mesenteric adenitis, or inflammation of the lymph nodes that are really abundant in that right lower quadrant? Or could this be just bad gastroenteritis? So those are kind of the top 3 things that come to mind. Of course, there's others, and then you can start to narrow that differential down with perhaps more questioning and, of course, your physical exam. All right, let's take another scenario. So here, let's say you have a 15-year-old patient that presents with abdominal pain. You're taking the history and you have this HPI. This is a 15-year-old with abdominal pain that's located in the right upper quadrant. It radiates to the right flank. It's dull and crampy in nature. It first began 6 months ago. It comes on every few days and lasts for 1 to 2 hours, reaching a severity of 8 out of 10. It's aggravated by eating fatty meals. It's relieved with food avoidance, and it's associated with nausea, vomiting, sclerolicterus, and dark urine. All right, so you put that together, what does that sound like? So that sounds to me like symptomatic cholelithiasis with choledocholithiasis, or a stone that might be obstructing the common bile duct. If you were to differentiate that from acute cholecystitis, the patient might have had this history of dull, crampy, intermittent pain, but usually in acute cholecystitis, that pain now becomes constant. That pain is pretty severe and can be associated with fever because now there's an infection. So here, I'm so thankful that that resident, when I was a medical student, introduced this to me, SRNOPDSARA. I have been using it literally every day since 3rd year medical school. Now, I'm a pediatric surgeon. I'm 5 years out from my fellowship. Literally, I probably use this over 10,000 times. I mean, no exaggeration. And you can see that when you put it in the bullet, or when I write it in the note, it's extremely clear. There's no jumping around. Oh, this is a 15-year-old that presents with diarrhea and some abdominal pain, and then they got some weight loss, and well, it's over in the right lower quadrant, and it's sharp, but it's a severity of 6 out of, you can't follow that. Like, how could you possibly follow that? So if you have a way you take your questions, you ask those same questions every time, you will get really good at making a differential diagnosis, and you are going to get really good at presenting patients both to your attending for a consult or every day on rounds. All right, I hope you enjoyed that. If you like these videos, make sure that you subscribe, tell your friends, share the videos, leave a comment, leave a like. I get totally pumped when you guys comment and give me feedback, and it helps me engage with you and let me know if I'm hitting the right notes, if I'm making videos on the right topics. So as always, I'll see you in the comments. Study hard, be safe. I'll see you next time.